Hello, everybody. I am Susana Salazar Lopez, OBGYN from CES University, and specialized in human reproduction from INSET Medellin. Today, I'm going to talk to you about ovulation induction medications. Ovulation induction is a term to describe the use of medication to stimulate normal ovulation in women with ovarian dysfunction. The medications used can also promote follicular development or enhance ovulation in patients with other causes of infertility, and they can be used to hyperstimulate ovaries for egg harvesting in ART. After the initial evaluation, simple modifications such as weight loss, 5 to 10% of body weight in obese patients, or treatment of the underlying cause allows the return of ovulation in some patients. The objectives are induce monofollicular development in order to have a healthy newborn, less invasive, less expensive, and a simpler option to achieve ovarian response, maximize the single pregnancy rates and minimize multiple pregnancy rates, and minimize the risk of hyperstimulation ovarian syndrome. Before to start talking about medications, I would like to quickly remind you how the hypothalamic pituitary ovarian axis works. The hypothalamic secretes GnRH that travels down the anterior pituitary and binds the receptors of the secretory cells of the adenohypophysis. In response to GnRH stimulation, these cells produce LH and FSH, which travel into the bloodstream. These two hormones plays an important role in communicating to the gonads. In females, FSH and LH act to activate the ovaries to produce androgens. Androgens form a negative feedback loop by inhibiting the production of GnRH in the hypothalamus. Now I'm going to talk about clomiphene. Clomiphene is the oldest and the most widely used ovulation induction agent. It is a non-steroidal triphenylethylene derivative, which is structurally similar to estrogen, allowing to bind competitively to estrogen receptors. It's a selective estrogen receptor modulator, blocking the estrogen receptor at the level of the hypothalamus. Increased output of gonadotropins from the anterior pituitary, thereby stimulating the final maturation of the follicles. Patients achieve ovulation in 60 to 85%. The dose is 50 milligrams a day for 5 days, since day 2 to 5 of the menstrual cycle. Do not increase the dose until after the second cycle, because only 2/3 responds in the first cycle. Clomiphene resistant are women who do not ovulate while receiving the 150 milligrams dose of clomiphene, and patients are at risk of excessive ovarian response. That means more than 2 follicles, dominant follicles. For that reason, ultrasound monitoring is recommended, and the maximum dose is 150 milligrams a day. The drug half-life is 7 to 14 days. Pregnancy rates is almost 10 times higher than in a spontaneous conception. Therefore, monitoring with ultrasound to detect multifollicular development and to advise the couple when to have intercourse should be performed. And the maximum of cycles that we should do are 6 cycles, not more than that. Treatment typically begins with 50 milligrams daily for 5 days. If ovulation occurs, it is expected 5 to 10 days after the least dose of clomiphene. We can also use HCG to schedule ovulation with 18 to 20 millimeter follicles. Clomiphene should be continued at the lowest dose that achieves ovulation. If the patient remains anovulatory, at 50 milligrams a day, clomiphene may be titrated in 50 milligrams a day increments with each cycle until ovulation is achieved with the lowest standard effective dose. The indications of use clomiphene are oligomenorrhea, group 2 of WHO, combined with gonadotropins in low response during the IVF cycles reduces the amount of gonadotropins needed, and it is not effective in hypothalamic amenorrhea or premature ovarian failure. Adverse events. The principal adverse event of using clomiphene is multiple pregnancy. Patients are at risk of having twins in 6 to 8% of cases, triplet in 1%, and quadruplets in 0.3%. Other side effects that can be presented with clomiphene are visual disorders, nausea, flushes, and breast discomfort. The antiestrogenic effects. It depends on the tissue. Vagina, cervix, endometrium alters quantity and quality of cervical mucus and sperm transport effects. It will depend on the dose and affects endometrial growth and development with variable growth with a tendency to reduce endometrial thickness, hindering the implantation and early embryonic development. The results are that 52 of women will ovulate in response to 50 milligrams of clomiphene. Additional 22 will respond with 100 milligrams. There is 30% of clomiphene resistance, especially in obese women and hyperandrogenism. Most pregnancy occurred in the first 3 cycles. The contraindications are pregnancy. It can cause congenital abnormalities, chronic liver disease, functional ovarian cyst, and visual disorders, blurred vision, and scotomas during and after previous therapy with clomiphene. This is the recommendation of the Society of Gynecologists and Obstetricians of Canada, published in 2018. The recommendation is clomiphene citrate has been proven effective in ovulation induction for women with PCOS, and where available should be considered the first-line medical therapy. Patients should be informed that there is an increased risk of twin pregnancy or higher order multiples with ovulation induction using clomiphene. The second medication I'm going to talk about is aromatase inhibitors that are used for ovulation induction, and the principal are anastrozole and letrozole. They are triazole derivatives that function as competitive non-steroidal inhibitors of aromatase. So remember the pituitary ovarian axis in the follicular phase. Estradiol is produced by the ovarian granulosa cells and exerts a negative feedback effect on FSH release from the pituitary gland. So, aromatase inhibitors prevent the conversion of androgens to estrogens. When aromatase is blocked, androgens cannot be converted to estrogens, thereby creating a low estrogen state, releasing the hypothalamic pituitary axis from the negative feedback of estrogen, increasing FSH secretion. Ovulation is achieved in 60% of the patients. Doses are 2.5 to 7.5 milligrams a day for 5 days since day 3 to 5 of the menstrual cycle. The half-life is 48 hours. And there are some other protocols that are first prolonged treatment courses for 10 days, or another that is a single dose regimen of letrozole 20 milligrams in day 3 of menstrual cycle. It's important to note that it has no effect on intrametal estrogen receptors, but you have to remember that it's off-label in the United States, and we also need to make ultrasound monitoring during aromatase inhibitors high cycles. Now I'm going to talk about estrogen impact. After letrozole treatment is ceased, estrogen levels increase immediately, which leads to a more abrupt decrease in follicle-stimulating hormone. This decrease makes gonadotropin support of multiple follicles less likely, and the associated increase in estrogens allows the production of cervical mucus and endometrial proliferation. Indications are breast cancer, ovulation induction. Letrozole is clearly indicated in clomid or clomiphene-resistant women, or in those who are unable to use clomiphene because of side effects such as vasomotor symptoms, visual changes, or headache. Women who have thin endometrium should also be used clomiphene, and women that have less than 7 millimeters when taking clomiphene, as the proliferation of the endometrium is stimulated by estrogen. Letrozole does not have the same anti-estrogenic effects that clomiphene. The side effects are vasomotor symptoms, headache, and visual changes. Patients should be informed letrozole is being prescribed off-label so they can make an informed decision and are not concerned when they read the package instructions. This is the recommendation of the ESOGC Clinical Practice Guidelines. Recent research has demonstrated both effectiveness and safety of aromatase inhibitors in their use for ovulation induction in PCOS patients, particularly in obese population, where clomiphene citrate is not available. Letrozole should be considered as an oral ovulation induction agent after counseling patients on its classification as off-label used by Health Canada. And this is the recommendation of the Australian guideline, also published in 2018. Letrozole should be considered first-line pharmacological treatment for ovulation induction in women with PCOS, with an ovulatory infertility and no other infertility factors to improve ovulation, pregnancy, and live birth rate. This is a meta-analysis published in 2018 in Human Reproduction. The objective was to evaluate the effectiveness of different ovulation induction agents, in particular letrozole alone and clomiphene citrate plus metformin, as compared to clomiphene alone, as the first choice for ovulation induction in women with PCOS. A total of 62 studies with 9,356 women were included. The first result was live birth rate. Compared with clomiphene alone, letrozole increased live birth rate. They found it in 3 RCTs with 1,043 women with RR of 1.43 and confidence interval of 1.18 to 1.75. The other outcome was clinical pregnancy. Compared with clomiphene alone, letrozole improved clinical pregnancy. It was found on 6 RCTs with 1,284 women with an RR of 1.45 and confidence interval of 1.23 to 1.70. Compared with clomiphene alone, there was insufficient evidence of a difference between clomiphene and metformin and clomiphene alone on live birth rates, as we can see in this first plot. Conclusion. This meta-analysis shows that in women with PCOS, letrozole improves live birth and clinical pregnancy rate and reduces time to pregnancy compared with clomiphene alone. Clomiphene plus metformin may improve clinical pregnancy rates, may reduce time to pregnancy compared to clomiphene alone, but there is insufficient evidence of a difference on live birth. This is a systematic review and meta-analysis of aromatase inhibitors in infertile patients with PCOS published in 2018. The objective was to evaluate the effectiveness and safety of aromatase inhibitors in infertile women with PCOS for the induction of ovulation followed by in-time intercourse or IUI. The primary outcomes are live birth and ovarian hyperstimulation syndrome. The secondary outcomes are clinical pregnancy, miscarriage, and multiple pregnancy. All RCTs of aromatase inhibitors used alone or with other medical therapies for ovarian induction in women with reproductive age with PCOS were included. The studies include 7,935 women who were infertile due to PCOS. The age was from 18 to 40 years, and there were 42 RCTs compared letrozole with clomiphene, ovarian perforation, and other treatments. The inclusion criteria were women with PCOS of childbearing age diagnosed by Criteria Rotterdam 2003. Exclusion criteria were women with hyperprolactinemia or Cushing, hypogonadotropic hypogonadism, or patients taken to IVF. 13 studies that include 2,954 complete with clomiphene with or without adjustment. Letrozole was found to significantly increase the live birth rate compared to clomiphene or for an OR of 1.64 and confidence interval of 1.42 to 1.99. 12 studies were include 2,336 women with compared letrozole with clomiphene that reported ovarian hyperstimulation, and it was concluded that the frequency presenting is similar in both groups. The conclusion were that letrozole appears to improve live birth and pregnancy rates in subfertile women with an ovulatory PCOS compared with clomiphene. There is high-quality evidence that ovarian hyperstimulation syndrome rates are similar with letrozole or clomiphene citrate. There was a high-quality evidence of no difference in miscarriage rate and multiple pregnancy rates. Now I'm going to talk about gonadotropins. Gonadotropins have been used over the last 25 years, were historically prepared by purifier urine, and today many medications are the product of recombinant technology. Based on available evidence, because ovulation induction may be similar regardless the preparation. Exogenous FSH stimulates proliferation of granulosa cells and follicular growth that together with LH stimulates estradiol production. LH stimulates the production of androgens in thecal cells that are subsequently aromatized to estrogen by granulosa cells. The goal of ovulation induction is to promote the growth and development of a single mature follicle. Indications: infertility caused by an ovulation either as primary treatment or after failure of other medications to induce ovulation. Group 2 of WHO, and hypogonadotropic hypogonadism that are patients of WHO1. This treatment with gonadotropins required experience with gonadotropin stimulation, careful follow-up, and the possibility of converting to IVF in case of multifollicular development. The gonadotropins preparation. Gonadotropins products for human use derived from urinary extract or recombinant technology, and all have similar effectiveness and safety. A systematic review found no evidence of a difference in either live birth or ovarian hyperstimulation syndrome rates among women with PCOS who were treated with urinary recombinant. These are some of the medications that we use with gonadotropins. For example, in INSER Medellin, we use Pergoveris, we use also Menopur, and we use Gonal. Both are gonadotropins. Gonal has just FSH, and Menopur and Pergoveris has FSH and also LH. The usual starting dose is 50 to 75 units for 2 weeks, with an increase of 25 to 37.5 units weekly in case of no response. In follicle development occurs, the same dose is managed until the same dose is maintained until the follicle cycle reaches 18 to 20 millimeters, followed by induction of final follicular maturation with HCG or LH. In most patients, ovulation is achieved, but some cycles must be interrupted or converted to IBS because of multifollicular development. With gonadotropins, pregnancy rates achieved in 20% to 25% per cycle. Remember that the use of gonadotropins is a second-line therapy because they have more risk of ovarian hyperstimulation syndrome and multiple pregnancy. Low doses are effective with less risk of multiple pregnancy. Gonadotropins plus metformin could be used instead of gonadotropin alone. PCOS with clomid resistance. Gonadotropin-induced ovulation is only triggered when there are fewer than 3 mature follicles and should be canceled if there are more than 2 mature follicles. The patient is advised to avoid and protect sex. Don't forget, gonadotropin therapy has more risk than oral induction agent, are more expensive, and should only be used by clinicians who have training and experience. The results achieved with gonadotropin treatment for ovulation induction. A systematic review of 13 studies evaluated ovulation induction with gonadotropins in anovulatory women and found pregnancy rates of 15% per cycle and 41% per patient over an average of 2.7 cycles. Women who were obese or insulin resistant required higher doses of gonadotropins. Insulin resistance, but not obesity, was associated with a lower pregnancy rate. The side effects are abdominal pain, ovarian hyperstimulation syndrome, ovaric cyst, ache, intestinal symptoms, and itch. The contraindications are ovarian cyst, ovarian failure, and pregnancy. These are the recommendation of the SOGC clinical practice guidelines. In case of PCOS with an ovulation cycles, gonadotropins should be considered second-line therapy for infertility. Gonadotropin treatment requires ultrasound and laboratory monitoring and is associated with high cost, high risk of cancellation due to higher than acceptable follicular development. risk of multiple birth, and ovarian hyperstimulation syndrome. And I'm going to talk about adjuvant therapy. Clomiphene plus glucocorticoids. In case of clomiphene resistance, in the setting of normal and elevated DA levels, the addition of daily dexamethasone of 0.5 to 2 milligrams or prednisone of 5 milligrams during the follicular phase to a clomid regimen shows an increase of ovulation and pregnancy rates when compared with clomiphene plus placebo. The largest randomized control trial studying this effect included 200 clomiphene-resistant women and found a 10-fold increase in the cumulative pregnancy rate with the addition of dexamethasone, 40% compared with placebo that achieved 4%. The recommendation is to use 3 to 6 cycles maximal because of side effects. So it increased ovulation and pregnancy rate versus clomiphene plus placebo alone. Insulin sensitizing agents. The recognition of an association between PCOS and insulin resistance had led to the use of insulin sensitizing agents of ovulation induction. Metformin is the most widely studied agent used in PCOS. Insulin is a big one, insulin sensitive agent that acts by inhibiting hepatic glucose production in the increasing peripheral glucose uptake. Does not stimulate secretion of insulin in case of hypoglycemia. Clomiphene plus metformin. It is considered in PCOS plus clomiphene resistant. With clomiphene alone, the birth rate is 22.5%, and with clomiphene with metformin is 26.8%, and with metformin alone, 7.2%. The dose is 1,500 to 2,000 milligrams daily, which can be titrated up from starting dose of 500 daily. The recommendation of the SOGC is that metformin combined with clomiphene may increase ovulation in pregnancy rates, but does not significantly improve live birth rate over of clomiphene citrate alone. Metformin may be added to clomiphene women with clomiphene resistance who are both older, aged than 28 years, and have visceral obesity, waist to hip ratio more than 0.85. To finish, I brought you some points. Ovulation induction is used to stimulate normal ovulation in women with ovarian dysfunction. The first line are oral medication, clomiphene and letrozole. Endotrophins are second-line therapy. Ultrasound monitoring is recommended. HCG can be used to schedule ovulation with 18-20 millimeter follicles. The goal of ovulation induction is to promote the growth or development of a single mature follicle. Monofollicular development sometimes can be difficult to achieve. Thank you very much.